This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. Welcome, everybody, to another episode of PHM from Pittsburgh. I am still your host, Dr. Tony Tarchichi. For those of you who are new here, welcome. And if you're a regular, welcome back. In case you forgot, I'm a med-peds trained pediatric hospitalist coming to you from UPMC Children's Hospital of Pittsburgh here at the Paul C. Gaffney Division of Pediatric Hospital Medicine. We've been doing this podcast since 2016. We're closing in on our 100th episode. And basically, it's a podcast looking at topics in pediatric hospital medicine since the field has become a field. And we have been marching through looking at all the different potential areas. And one area we have come up short in, and that's mostly my fault, is endocrinology. And we are luckily here to kind of begin to remedy that today. We're talking to you about a very important topic, adrenal insufficiency. Now, if you know me at all, you know I am not adept to be leading this conversation. So that's a helpful thing to know. And I'm fortunate enough, for the first time ever, I think, we have three expert guests on our show talking about this very important topic. So here's what we're going to do. I'm going to introduce them all, and then we're going to say hi to them, do our disclosures, and dive right in. So this may take a little longer. It's the first one I've had three, but everyone bear with me. So first is my good friend, Dr. Selma Feldman-Witchell. Dr. Witchell is a tenured professor emeriti of pediatrics at the University of Pittsburgh Medical Center, Children's Hospital, Pittsburgh, and the University of Pittsburgh School of Medicine. She's the immediate past program director for the Pediatric Endocrinology Fellowship Training Program right here at UPMC Children's. She co-chairs the Differences in Sex Development Committee at the UPMC Children's Hospital of Pittsburgh. She got her Bachelor of Arts degree from Oberlin College and her medical degree at University of Pittsburgh, graduating a member AOA. She completed her peds residency at Children's Hospital Medical Center, University of Cincinnati, and her endocrinology fellowship at Children's Hospital of Pittsburgh. And she's interested in the physiology and genetics of the hypothalamic pituitary gonadal and hypothalamic pituitary adrenal axes. And she's the past chair of the Pediatric Endocrine Society Education Subcommittee. She served as the co-chair for the 50th anniversary annual meeting of the Pediatric Endocrine Society in 2022. She was elected to the board of directors of the Pediatric Endocrine Society. She's an active member of the Endocrine Society Annual Meeting Steering Committee and associate editor for the Journal of the Endocrine Society. She's a past president of the Androgen Excess Society. She's published over 200 articles, reviews, and chapters, and is definitely an expert in this area. So we're going to welcome everybody all at once when we get through everyone's intro. So next is Dr. Maria G. Voiazzi. She's a pediatric endocrinologist at the Children's Hospital of Philadelphia, CHOP. She's a professor of pediatrics and a director of the Adrenal and Puberty Center at CHOP, which is dedicated in the care of children with gonadal and adrenal disorders. As the director of the center, Dr. Voiazzi leads a large multidisciplinary program for congenital adrenal hyperplasia and a busy inpatient and outpatient service for children with adrenal insufficiency. Dr. Voiazzi has conducted clinical and lab research in the areas of metabolic bone disease, CAH, and the effects of glucocorticoids and androgens on health and diseases. Her programs participate in many recent industry trials to bring new therapies in congenital adrenal hyperplasia and collaborative research in adrenal disorders. And last but certainly not least, we have Dr. Alexandra Ahmet. She is a division chief for pediatric endocrinology at the Children's Hospital of Eastern Ontario in Ottawa, Canada, and is an associate professor of pediatrics at the University of Ottawa. She was the first author of the Joint Canadian Pediatric Society and Canadian Pediatric Endocrine Group statement on glucocorticoid-induced adrenal suppression. She's had a clinical research and educational focus on adrenal insufficiency, specifically related to the adrenal suppression, adrenal testing, and prevention of adrenal crisis through education. I have not had a group this large and this distinguished on this show before, so thank you all very much for coming on. I really appreciate it. Welcome.
Thank you. It's great to be here.
Good. Well, so we're going to do our disclosures. We'll go right around the horn. The order, Selma, I'll go first, then it'll be you, then Maria, then Alex.
Okay.
All right, so we'll do around the horn. I have nothing to disclose. Selma, you're up.
I'm a consultant for Neurocrine Biosciences and my organizational affiliations with Endocrine Society and Pediatric Endocrine Society.
And this is Maria, and I have research support, and also I act as consulting with Neurocrine, Crinetics, and Eton.
Alex, and I've sat on an advisory board for Dexcom Canada.
All right. Now, it has been a handful of times where I've had an episode created where someone has come up to me and said, Tony, I think we need to do an episode on X, Y, or Z. This is one of those moments. And when Selma came up to me and said, Tony, we need to do an episode on adrenal insufficiency. And so, Selma, I would love it if you would tell us, or all of you would tell us, why you felt this was such an important episode to do to get us all together.
Okay. Well, I guess I'll start. We were at a conference of pediatrics on a case of children's about the adrenal. And I felt that education about adrenal insufficiency would benefit all of us, particularly the house staff and other subspecialties. And part of it comes from a long time ago. I had an adolescent male patient who played baseball every Friday afternoon. It was the summer, it was hot, and he lived a few hours outside of Pittsburgh. Every Friday afternoon, he would collapse on the baseball field. He would be taken to the local hospital where they noted his sodium was low and his potassium was high. They'd give him fluids to correct his electrolytes and send him home. After the third time that this happened, the parents said, we need to go to Children's Hospital. So they brought this young man, and turned out he had primary adrenal insufficiency with a very high ACTH level. And so throughout my career, it's been important to recognize patients with adrenal insufficiency for multiple causes and provide appropriate daily treatment as well as emergency treatment. So I think we can sort of talk a little bit about the various signs and symptoms of adrenal insufficiency. So I don't know if Maria or Alex want to chirp in.
I can start, and I want to tackle the signs and symptoms of acquired primary adrenal insufficiency that you described. And the tricky part is that the onset can be insidious. The symptoms can be slowly progressive and can be non-specific. So the kids may experience something like fatigue, morning nausea, sometimes morning vomiting, some weight loss. So the signs are not always easy to pick up. And for this particular reason, a good number of these kids are not diagnosed, in a short period of time. A good number of them, it takes good 1 year for the diagnosis to get established. And then as the disease progresses, they may have some other symptoms. They may have some kind of hemodynamic instability with dizziness, orthostatic hypotension. And on exam, sometimes we can also have some specific signs, something like hyperpigmentation, or in certain cases, something a little bit different like vitiligo.
So we've also been talking among ourselves about adrenal insufficiency due to glucocorticoid use. And so I don't know if Alex wants to comment a little bit about secondary adrenal insufficiency.
Yeah, so in primary adrenal insufficiency, as we all know, there's a problem at the level of the adrenal glands. In secondary or tertiary adrenal insufficiency, there's a problem at the level of the hypothalamus or the pituitary gland because cortisol production's under circadian regulation, which is controlled by the HPA axis. So normally our hypothalamus makes CRH that stimulates the pituitary gland to make ACTH, and the ACTH stimulates our adrenal glands to make cortisol. And then cortisol goes back up to our hypothalamus and pituitary gland and down regulates cortisol production. So in a secondary or tertiary form of adrenal insufficiency, it's not a problem in the adrenal glands, but rather a problem in the hypothalamus or pituitary gland. And so we don't have that stimulation of ACTH at the level of the adrenal glands to produce cortisol. In glucocorticoid-induced adrenal insufficiency, what happens is exogenous glucocorticoids in the doses that are typically given for anti-inflammatory effects, so for asthma or for cancer or for many other pediatric conditions, will bind at the level of the hypothalamus and at the level of the pituitary gland and will downregulate ACTH production. And over time, that will lead to adrenal insufficiency. And this type of adrenal insufficiency is a little bit more tricky to recognize because we don't have all of the classic signs that we see often in primary adrenal insufficiency. So we don't get hyperpigmentation. And one thing that a lot of clinicians associate with adrenal insufficiency is hyperkalemia, which we don't see in central or secondary adrenal insufficiency because it's only cortisol deficiency that we develop. We don't develop mineralocorticoid deficiency. And I don't know, Selma, we had talked about a case. I don't know if you're interested in hearing about that case.
Well, can I ask a question?
Sure.
So, Alex, in terms of glucocorticoids or steroids that you take to trigger secondary adrenal insufficiency, what about, we see a lot of inhaled steroids in pediatric hospital medicine, like fluticasone or Flovent, et cetera. Do you see it with that?
Absolutely. So inhaled corticosteroids are probably the most frequent cause of undiagnosed glucocorticoid-induced adrenal insufficiency in children because people often think that they're safe and that they're not systemic, so that risk doesn't exist. The risk exists, but it exists mostly when we're using high doses of inhaled corticosteroids. So if you look at the asthma guidelines, the recommendation is that we're only using those high doses for prolonged periods of time in children with severe asthma, and that should be done in consultation with an expert. But if we look at prescribing practices, we often see, 500 mics of fluticasone daily being prescribed, and that is what's leading to adrenal suppression from inhaled corticosteroids. So as clinicians, what we can be doing is thinking about what we're prescribing, always using the lowest effective dose, and reassessing those doses. Because what we do see is if, for example, a child goes into the emergency department because they've had an asthma exacerbation and the dose is bumped up, and then there's no follow-up, then they stay on those doses and they can present with acute adrenal crisis, actually, related to adrenal insufficiency when it's missed. And that's what first drew my attention to adrenal insufficiency as an entity. Because when I was a trainee, we saw a young child who had had a hypoglycemic seizure, presented to a quaternary care hospital, was admitted to the ICU with an encephalopathy, working at this encephalopathy and this hypoglycemia, and no etiology was found. And the child was discharged home, was very fatigued, had kind of nausea, had very poor linear growth, which are symptoms that we see with adrenal insufficiency, and eventually made their way back to their pulmonary clinic, where they referred to endocrinology, and the child was found to have undetectable cortisol levels on stimulation testing. Was treated for adrenal insufficiency and completely recovered, and was put onto steroid-sparing agents for asthma. So just kind of an example of how significant this can be if it's missed.
In terms of a pediatric hospital, someone who's seeing kids on the inpatient side, I mean, you guys are three real big experts in the field. What do you see as a presenting symptom for a child hospitalized when it's undiagnosed adrenal insufficiency prior to you all coming in? That was a great example that Alex threw out about high dose inhaled steroids that can trigger it. But is there anything else you've noticed that, when we diagnose new kids in the hospital setting, here's what they typically come in with or present with? I don't know if it's a good question or not.
Well, let me start by tackling a little bit the newborn, and then we can expand it to other ages. So I want to share with you a recent patient of ours who was born full term. It was a boy, completely normal birth weight, discharged home, no problems. And then a week down the line, our service got notified by the state that the newborn screening for this baby was positive for CAH. So to remind everyone, CAH stands for congenital adrenal hyperplasia. It's a disorder of the adrenal gland. The adrenal gland is missing an enzyme that is critical in making cortisol, and these kids have adrenal insufficiency, and most times they have also aldosterone deficiency. So when we got this report from the newborn state, we called the family, and the kid was fine. The family had not appreciated anything. It was their first kid, was breastfeeding, but still, because of this positive newborn screening, we sent it to the hospital, and the baby did have hyponatremia. The sodium was 130, the potassium was trending high, the bicarb were trending low, around 15. So the baby had evidence of mineralocorticoid deficiency, which is consistent with salt wasting. So the baby was admitted in the hospital. The first thing we do is, in cases like this, is we confirm the diagnosis by sending a blood sample for the biomarker for CAH. The biomarker has a long name. It's called 17-hydroxyprogesterone. And we don't really wait for the results, but we start replacement immediately. So we replace the cortisol with hydrocortisone and the missing aldosterone with fludrocortisone. And we did that, and the baby did beautiful. So I wanted to share this case first for two reasons. One is to show how important the newborn screening is in picking up these cases early. The goal is to avoid the adrenal crisis early in life. And the second reason that I wanted to share this case is because the newborn screening is particularly relevant in boys with CAH. In girls, the girls can be picked up immediately after birth, because even in the hospital upon delivery, because they have some genital changes. So as you recall, in CAH, you have a hyperplastic adrenal gland that makes a bunch of male type of hormones that are called androgens. And in boys, it doesn't really make any difference in terms of genital development. So they look perfectly fine and they can be missed. While the girls, they have some genital differences and atypia. And a newborn who has this kind of genital changes, needs to, the physicians are prone to figuring it out and picking it before discharge. But for boys, the newborn screening is there to help us out.
Yeah. I mean, coming back to the boys, prior to newborn screening, as Maria's parents said, the baby seemed to be feeding fine. It was their first baby, so they didn't have any experience for anything being differently. But these, in the past, baby boys would get very, very ill very quickly. But that's sort of an obvious situation of acute adrenal insufficiency. But for the kids that are on chronic steroids, whether it's inhaled steroids or rheumatologic diseases or GI diseases, I think we sometimes become too complacent. We being the general pediatricians, not recognizing that the steroids have additional effects besides being, the benefits for their underlying disorder. So we as endocrinologists have been trying to educate our colleagues about the use of high-dose steroids, because sometimes the symptoms may be very subtle. Sometimes it's obvious in terms of decrease in linear growth velocity because of high-dose steroids, but sometimes it's just not feeling well or abdominal complaints. And the worst case scenario is the child really doesn't have any symptoms until they get an intercurrent illness, particularly a GI illness. They can't absorb their daily steroid or inhaled steroid as well. And then they get really sick very quickly. And again, we sometimes don't think of, well, maybe they're having adrenal insufficiency. We just start treating them for an intercurrent illness. And I don't know if Alex, if you want to expand on that.
For sure. Thank you, Selma. And I think that's really important, kind of that messaging, both for adrenal suppression, but also for adrenal insufficiency in general. The last two cases of primary adrenal insufficiency that I've seen in my practice have been kids who have come to healthcare providers several times for abdominal pain, nausea, unexplained, and were quite unwell by the time they actually were diagnosed. So that's something that we should be thinking about. If there's a child with insidious symptoms, we should be thinking about, without a clear etiology, we should always be thinking about adrenal insufficiency as a cause. And if some form of glucocorticoid is on their medication list, then we definitely should be thinking about adrenal insufficiency as a cause. And importantly, I talked about high doses of inhaled corticosteroids as putting children at risk. And we typically think about for a prolonged period of time. So 3 months or more, we might think about those high doses. In children who are on other medications, we need to look to see if there's an interaction. So I have seen cases of severe adrenal insufficiency in kids who are on lower moderate doses, but also on antiretrovirals or antifungals, which potentiate the effects of inhaled corticosteroids. So that's a really important thing to keep in mind. And also for the systemic glucocorticoids, I think clinicians think about a little bit more, like that risk of adrenal suppression. But we typically think if they've been on high doses, and high doses are any dose that we're using for anti-inflammatory effects for greater than 2 to 3 weeks, then we need to start to think about that risk of adrenal insufficiency or adrenal suppression from the glucocorticoids. And as Selma said, sometimes they're sick kids, so the symptoms kind of mimic their underlying condition. So we need to think about it so that they don't end up in adrenal crisis secondary to an intercurrent illness.
So in terms of if we want to go evaluate a child for adrenal insufficiency, what laboratory or other clinical tools would we choose to use? I mean, Maria talked about the obvious one of 7-hydroxyprogesterone if we're concerned about congenital adrenal hyperplasia.
So if we want to put the diagnosis, then for adrenal suppression, the first thing that we do is to measure a morning cortisol. And the word morning is important because cortisol naturally peaks around 8 o'clock in the morning. So it's very important to measure the cortisol early in the morning when it's the peak, when it is peak, and get a value. If the value is very low, then we have kind of documentation of adrenal suppression, and we treat the child appropriately. If the cortisol level is somewhere greater than 10 or 12 micrograms per deciliter, then we are comfortable that the child does not have adrenal suppression. If the level is somewhere in between, then there is additional endocrine testing that can be done, like the ACTH stimulation test that can help us establish the diagnosis. But the first step in starting the evaluation is the morning cortisol value.
And an important part of that if we're evaluating for adrenal suppression is that we're holding any glucocorticoids inhaled or systemic for 24 hours, at least 24 hours prior to that testing. Otherwise, it can either interfere with the assay or it can cause kind of false suppression because there will be acute suppression that may not be chronic. So as part of that first morning cortisol testing or as part of our ACTH stimulation testing, it's really important to hold those glucocorticoids.
And so we are also very passionate about recognizing sick children with adrenal insufficiency. So we'll shift gears. We've talked a little bit about recognition and that the fact that some patients have very subtle symptoms, maybe stomach ache or weight gain. We've talked about secondary suppression with medications. And again, we're also worrying more about thinking about chemotherapies or opioid exposure can cause adrenal insufficiency. But, moving towards, patient who's treated. Yeah, go ahead, Maria.
Selma, let me also add to something that we haven't addressed. Quite rare, but there are some babies who have structural abnormalities of the pituitary hypothalamic area. Can be genetic, can be also the result of a CNS malignancy, but these conditions also can lead to adrenal insufficiency with additional pituitary deficiencies as well.
And along those lines, it's important if a patient has hypothyroidism and adrenal dysfunction to treat the adrenal before you treat the thyroid, because treating the thyroid first may put the patient into acute adrenal crisis. So something else that we need to be cognizant about. But we've talked about different causes and a little bit about daily treatment, but I think we're also very passionate about recognizing when a child's ill and how to treat illness.
I guess with respect to that, we talked a little bit about how do we diagnose adrenal insufficiency, but as clinicians, particularly clinicians who may be in the acute setting, we need to be very aware that anyone with known or suspected adrenal insufficiency requires what we call stress dosing during an intercurrent illness, an injury, or surgery. So in a healthy adrenal gland, if the body is exposed to any form of physiologic stress, we make more cortisol. And that has an important effect on glucose, on blood pressure, on inflammation. And that's actually critical. It's a critical part of our response. But in individuals with adrenal insufficiency, they're not able to mount that stress response. And so we need to mimic that for them. So any patient with known adrenal insufficiency who comes into an acute setting with an injury, a surgery, or an illness, the clinicians need to prioritize those individuals and get them high doses of glucocorticoids. We call those stress doses immediately in order to prevent an adrenal crisis. And our glucocorticoid of choice is hydrocortisone because it has both glucocorticoid and mineralocorticoid effects. So it's better at supporting blood pressure. And if there's a mineralocorticoid deficiency in high doses, it can help to support that as well.
From the standpoint of pediatric endocrinologists, when we're treating a new patient and periodically as we see patients over the years, we educate families about stress dosing. And typically we recommend triple their usual oral dose. I'm assuming they're on a replacement dose that is physiologic, somewhere about 8 to 12 milligrams per meter squared per day is a relatively physiologic or high physiologic replacement dose. So typically we do triple their dose is sort of the standard. And we also teach families how to use IM injections of Solu-Cortef. And parents should have a kit at home where they have the Solu-Cortef. That kit, rather than having that kit follow the child everywhere, there should be a kit at school. There should be a kit at grandma's house. Any place the child spends a lot of time should have a kit to give the injection, and the kit should have the medication, syringes, alcohol swabs, anything that's needed to give the injection.
And that injection is essential. So the tripling or giving about 30 to 50 milligrams of hydrocortisone per meter squared. We work in meters squared, but we can also give standard doses during moderate illness. Is really essential. But if the child is vomiting or if they're more unwell, that's when we would give the injectable hydrocortisone. And we also need to have people in acute care. So EMS can't always provide it. And there's some advocacy going on to ensure that EMS can provide, but recognizing that patients might arrive in the emergency department without having received that high dose of hydrocortisone. So that's something that needs to be given as soon as the child arrives, particularly if there's a vomiting illness, because we know that the risk of adrenal crisis and death from adrenal crisis is highest in individuals who have a gastrointestinal illness. And that education is really important for this, education for the clinicians. So it's so great that you've invited us to come and talk today, but also education for patients and families, like making sure that they recognize that when their child is unwell, that they need to closely follow those guidelines and provide that stress dosing in order to prevent adrenal crisis.
One thing that I also want to emphasize is teaching the families themselves to administer the emergency injection, because it's not an absolutely certainty if they run into any problem and they call EMS, that EMS will be able to administer the medications because of many regulatory issues that are very different from state to state or from country to country or area to area. So it's not an absolutely certainty for the family that they will call EMS and EMS will be able to provide this life-saving medication to their children. So it's very important not only for the parents, but also for caregivers to know how to do the administration of the emergency hydrocortisone.
Yeah. Maria brings up an important point. We as physicians assume you call 911 or the emergency service, and the ambulance will have Solu-Cortef, and the basic life support person who are manning the ambulance can give it. Unfortunately, the United States and Canada and many other areas throughout the world are a patchwork quilt where in most instances they don't carry the medication and they're not certified to give it. So that's why we emphasize that families learn how to give the medication.
You all have brought up adrenal crisis a number of times. I wonder if you could define it for our audience.
Vomiting, hypotension, hypoglycemia, fatigue, lethargy, fainting, essentially very, very sick, and it can happen very, very quickly. And there have been some reports of patients who did everything right in terms of increasing their dose, but they had a gastrointestinal illness and weren't able to absorb the medication and still passed away. I think those were young adult men, not pediatrics, but I think it behooves us to remember that GI illnesses can cause kids to become very sick very quickly, even if it's just the flu.
And that's where peripheral administration of glucocorticoid, of hydrocortisone, is essential. And studies have also suggested that upon arrival in the emergency department, there's often a long wait, and that should be an immediate. Like if someone comes in, they have adrenal insufficiency, they have an intercurrent illness, they need that IV or IM hydrocortisone immediately to prevent adrenal crisis and or death.
Yeah. And importantly, if you give somebody a dose of Solu-Cortef when they didn't really need it, you're not going to hurt them. You're going to hurt them it's an act of omission is going to be more harmful than the act of commission. And the other thing, just to mention about Solu-Cortef, it comes in a vial with a liquid and the powdery medicine, because the powder is not stable mixed up solidly. So families have to mix the medication and draw it up in syringe and then give it. So again, education of the families is really important in terms of how to administer the medication.
There are a number of resources for families. There are YouTube videos about how to give the Solu-Cortef. It's just important that we're providing those resources to the family so that they know where to look and to learn, because education, we know that education needs to be repeated. So for anyone who's prescribing glucocorticoids, for example, where the children may be at risk of adrenal suppression, that risk and understanding what to watch for needs to be repeated at each visit. Or for people with established adrenal insufficiency, the stress dosing needs to be repeated and well understood. Otherwise, it's missed.
And finally, I want to bring to people's attention that we instruct our patients to wear a medical alert bracelet, especially for teenagers or young adults who live independently. If they get into an unfortunate situation where, let's say, they have a serious injury or trauma and they're unresponsive and someone arrives to help them out, the medical alert will identify this individual as having adrenal insufficiency and will get appropriate help immediately. So we do ask our patients to wear a bracelet or a necklace or whatever they like, as long as it's a medical alert bracelet. And even for CAH, we just say adrenal insufficiency on the bracelet to point the emergency provider towards a corticoid replacement.
Yeah, and that it's sometimes a challenge to get teenagers to wear medical alert devices because it's embarrassing. But we emphasize it, and I often threaten my teenagers or college students that they have to take their parent with them everywhere if they don't want to wear it. And so that usually convinces them that maybe they should wear it, at least when they're out.
I've never used that. I will next clinic.
Yeah. And occasionally parents talk about putting a tattoo on the child. One time, reverse tattoo. Yeah.
That's good.
The other thing that is happening more and more, which is great, and it's something we should be thinking about, is using alerts in our electronic health records. So in Epic, if people are using Epic, we can add an alert beneath the demographic information. And at our center, we've linked it with a diagnosis of adrenal insufficiency. So if any of the diagnoses of adrenal insufficiency are added to the problem list, then there's an automatic alert. So if anyone opens the chart, there's a big red banner that says adrenal insufficiency, so that clinicians know when that child arrives that they need to treat them with Solu-Cortef if they're unwell.
Yeah, so that's something for us as we're redoing our EMR in Pittsburgh, we need to think about doing, because we're in the process of redoing it. The other thing is there are steroid cards that are being developed for adult and for children with the patient's name and brief information about giving IV fluids and giving Solu-Cortef and a little bit with doses, and sort of being very simplistic about the doses for Solu-Cortef. There's small, medium, and large in terms of the size of the patient. So small would be an infant, 25 milligrams, medium, young school-age child, 50 milligrams, and larger, older child or adult would be 100 milligrams. So that's sort of the keep it simple, stupid approach to how do you dose Solu-Cortef so that you don't have to remember complicated formulas or weigh the child, just small, medium, and large, and small, medium, large dose. And if you give a little bit more, you're not going to hurt the patient. Other things we should talk about? Tony, other questions you have?
I have a question. You brought up opioids causing adrenal insufficiency. I'd read that in one of the articles, but could you explain that at all? Any of you? How we think that works, how that works?
I can start.
Okay.
So opioids can cause central suppression of ACTH signaling, and because of that, the adrenal gland becomes atrophic, and the individual develops adrenal insufficiency. It is primarily recognized in young adults, and I can't tell you what percentage of them they have it, but the number is significant because our adult colleagues diagnose more and more of these patients. So the clinical picture is very similar to central adrenal insufficiency. And as we treat teenagers, a number of them, I suspect, will come up with this specific diagnosis as well.
Maria, can I ask, would you see this in someone who had a broken bone and needed to take opioids for a short period of time? Or is this more someone who's chronically using it, whether as drugs of abuse or for a medical condition?
I suspect is someone who has significant long-term exposure and not just one-time thing.
And then the other question that had come up, and in the hospitals community, this comes up a lot. Our intensive care colleagues, for patients that come into the ICU, will give them the hydrocortisone 100 milligrams of hydrocortisone IV. Whether or not there's sometimes an unknown patients that come in, they're maybe not sure, they give it to them. It sounds like from what you've said to me, that's the right approach. It's not going to harm the patient. And if there's adrenal insufficiency, either primary or secondary, this will be life-saving. But I know this has come up in conversations in the past, so don't let me be wrong. Am I extrapolating what you're saying correctly?
The one thing I would say is if someone comes in with possible adrenal insufficiency, in endocrinology, we always love our critical samples. So if there's time, drawing a critical sample that includes a cortisol level can be very helpful to us diagnostically. But for sure, if there's any suspicion of adrenal insufficiency, we want to draw that critical sample and give the glucocorticoid. Or if we can't draw the critical sample, we want to give the glucocorticoid. In the ICU, it may be a little bit different. So for sure, if they're suspecting adrenal insufficiency, absolutely that's the right thing to do. There's also like a relative adrenal insufficiency of critical illness, which is a totally different kind of ballpark.
Right.
It's a different entity that we don't fully understand, but it's thought to be related to critical illness. It's also described in premature neonates. In premature neonates, it's thought to be secondary to kind of an immature adrenal gland. We also have lower binding globulins. So our total cortisol levels, which is what we usually measure, are going to look lower even if free cortisol levels are higher. So it's a little bit of a trickier thing to really describe. I don't know if Maria or Selma have other thoughts about that. But that's not kind of this primary adrenal insufficiency. It's something that's secondary to critical illness, and it may be managed a little bit differently.
Yes, I mean, I totally agree with whatever Alex said. The diagnosis of relative adrenal insufficiency in the context of critical illness is kind of tricky. And again, the entity is not fully understood. But in general, if you're dealing with life and death, sometimes you do everything under the sun to help this person. And then once the illness is over, then that's where the endocrine team comes along, and we can help you guys wean off the steroids and do the appropriate testing and determine, was this like a transient issue? Is this something that needs to be addressed on the long run? But don't forget that once the steroid exposure is over, the individual recovers, even with steroid-induced adrenal insufficiency. Eventually, without steroid exposure, the individual gland will recover. And we can do appropriate testing and document it. So that's another important message I think I would like to bring into this group, is that if we diagnose a kid, let's say, on inhaled steroids with adrenal insufficiency, that's not the end of the story. The story for endocrine just starts at that particular point when we want to minimize the exposure to steroids based on underlying illness, minimize exposure, eventually get the kid off. And then the adrenal gland will recover. The recovery period can be variable, but eventually will recover. And the individual needs to team up with an endocrine doctor to do the appropriate testing at that point.
That's super important messaging. And the other thing that sometimes when I talk about adrenal suppression, people say, oh, maybe I shouldn't be using inhaled corticosteroids. And my message is inhaled corticosteroids are the mainstay of asthma therapy. It reduces systemic steroid use and is life-saving. So that's not the messaging about adrenal suppression. The messaging is use the lowest effective dose with regular reevaluations. And as Maria said, it will recover over time. So it's something that's manageable. So that's really important.
Yeah, breathing comes before all else.
Yeah.
Okay, you can't breathe. But I think the point is for, rheumatologic diseases or other diseases that require high-dose steroids, that first stage of weaning is up to the subspecialist regarding the course of the disease. And when the patient is on a relatively physiologic replacement dose, that's the time to call endocrine so that we can help with the weaning. And these are medications that should not be taken one day and stop the next because your patient's going to have adrenal insufficiency. And so you sort of work with the family to develop a plan to switch to hydrocortisone and slowly wean them over time and eventually test, morning cortisone and ACTH to see if they've recovered. And the length of time for the weaning sometimes is often proportional to the duration of time they have been on high-dose steroids so that the adrenal recovers. Again, we don't have any hard, fast, evidence-based data, but I think generally if somebody's been on steroids for a longer time, we think it'll take longer for the adrenal to recover. No data. And the other important thing about the ICU is as the patients recover, it's important that they go home with knowing whether they do have adrenal insufficiency and require daily treatment, or they were critically ill, they required steroids for 1 to 2 days and then can come off. And so again, it's important for the intensives to think about that. And, we're happy to participate in the care of patients to try and parse out if somebody needs to go home on steroids because they truly have adrenal insufficiency or whether their adrenals work fine, they were just critically ill. And Alex and Maria brought up sort of the acute care, the critical care relative adrenal insufficiency. And it's not clear really what that is. A lot of thoughts about what it might represent. And initially, it was one of the medications used for intubation interfered with steroidogenesis. And so a lot of the early data about that is based on use of a specific medication that interfered with steroidogenesis. But, there are some patients who clearly benefit from receiving, high-dose hydrocortisone during the first day or so of critical illness.
And to add into this, the high doses of glucocorticoids in the case of ICU and critical illness may have some additional benefits beyond the strict definition of adrenal insufficiency. So when you do high doses glucocorticoids, definitely you affect blood pressure or hemodynamic parameters. So you may have some additional benefits of high dose glucocorticoids. I don't want to be perceived as someone who is advocating this treatment. I'm just putting some general thoughts in a very complicated kind of topic.
Yeah. And when you use high dose steroids, they also raise blood sugar. So we need to pay attention to blood sugar in these patients.
Now, this was incredibly helpful to me, but I always, I'm the novice in the group, clearly. So all of this was incredibly helpful to me. Is there anything we didn't cover that you felt was important to cover?
I think we got most of our ideas. So,
well, to be honest, I want to go back into where we started with this undiagnosed kid with primary adrenal insufficiency, having subtle symptoms, to bring into the medical attention to have appropriate testing. I want to kind of cite a recent, very unfortunate event. And I'm sorry to close with this unfortunate event, but it just highlights why we came to this podcast. It's an 8-year-old girl flying for vacation, and she had a sore throat, and then she collapsed during the flight and died. And of course, the sore throat cannot explain the event. So the family had a medical, an autopsy done, and she was found to have Addison during, after the autopsy. And looking back, she did have signs and symptoms of adrenal insufficiency, but unfortunately were not diagnosed, went into her flight, had this concurrent illness, had adrenal crisis during the flight, and died.
And I think that really just speaks to the importance of thinking about adrenal insufficiency in someone who comes in with nonspecific symptoms, and also recognizing the extreme importance of stress dosing if we're suspicious for the possibility of adrenal insufficiency.
Yeah. I mean, the goal is that we make the diagnosis and not the pathologist.
So then, so if I could, as the hospitalist and not the endocrinologist in the room, if I am seeing somebody in the hospital setting with vague symptoms, one of the primary screening methods I'm going to use, as we talked about, if the patient's very ill, I'm going to do a random cortisol before if I decide to give them something. But if I'm working them up and I have some time, around 8 a.m. in the morning, which is the peak time for the cortisol, I'm going to get a random cortisol level to see what it is. If it's low, and I'm saying low is in our hospital, I think less than 3 or undetectable,
Right.
then that's going to tell me I got to call. For me, I have to call my endocrinology colleagues and consider like an ACTH stimulation test. Mm-hmm. If I'm above 10, I'm not worried about adrenal insufficiency at this point. Mm-hmm. If I'm in between 3 and 10, let's say, I am confused and I may or may not call for help depending upon the rest of the clinical scenario. Does that sound right?
Yeah, definitely less than 3, likely adrenal insufficiency, call us. 3 to 10 questions, call us. And together we can parse out what's going on for the patient. Greater than 10, likely the patient doesn't have adrenal insufficiency. You can still call us if you need us and have questions.
Well, this was so helpful. I can't thank the three of you enough. Alex, Selma, Maria, thank you for coming on the show.
Oh, you're welcome. Thanks for having us and inviting us. I invited myself pretty much, but
it's an open invitation for all of you. If I have other endocrine topics that we need to discuss, I'm going to email and call because this was super helpful. I loved it a lot. Thanks again.
Oh, you're welcome. Thank you for having us. Happy holidays to everybody.
Happy holidays to you all. Happy holidays to everybody listening.
As a reminder, free CME is available, and it's courtesy of the University of Pittsburgh. Just click on the link under the podcast description and follow the instructions. Thank you to the UPMC Children's Hospital of Pittsburgh, and especially the Paul C. Gaffney Division of Pediatric Hospital Medicine.
Thank you again to our expert guests, and special thanks to all of you who take the time to join us. We know that your time is valuable, and we appreciate you sharing it with us.
Please feel free to email my dad at tony.tarchichi@chp.edu for any questions, comments, or podcast ideas.
As always, thank you for listening.